The glomerular filtration barrier. How the kidney filters 180 liters of plasma per day. Every day, your kidneys filter approximately 180 liters of plasma, almost 50 gallons. Yet they retain virtually every protein in your blood, while allowing water, electrolytes, and small molecules to pass freely. This remarkable feat is accomplished by one of the most exquisitely designed structures in the human body, the glomerular filtration barrier. Welcome to Medical Sciences Unfolded. Today, we explore the structure, function, and clinical consequences of disruption of the glomerular filtration barrier, the gateway to understanding all forms of kidney disease. The glomerular filtration barrier consists of 3 layers that work in concert. The first layer is the fenestrated endothelium, the innermost layer lining the glomerular capillaries. These endothelial cells are perforated with fenestrae, pores approximately 70 to 100 nanometers in diameter, that freely allow passage of water and small solutes, while being coated with a glycocalyx rich in negatively charged heparan sulfate proteoglycans. This negative charge repels negatively charged proteins like albumin. The second and most important layer is the glomerular basement membrane, the GBM, a continuous sheet of extracellular matrix composed primarily of type 4 collagen, laminin, nitrogen, and heparan sulfate proteoglycans. The GBM is approximately 300 to 350 nanometers thick and provides both a size and charge barrier. Molecules with a molecular weight above approximately 70 kilodaltons are largely excluded by size. Negatively charged molecules are further repelled by the fixed negative charges in the GBM. Albumin, with a molecular weight of 69 kilodaltons and a strong negative charge, is almost completely excluded. Less than 0.02% of plasma albumin crosses the glomerular barrier. The third layer is the most fascinating, the podocytes, highly specialized epithelial cells that wrap around the capillary loops with long primary processes and secondary foot processes called pedicels. Adjacent pedicels from neighboring podocytes interdigitate like interlocking fingers and are bridged by a thin membrane called the slit diaphragm. The slit diaphragm contains specific proteins, nephrin, podocin, CD2AP, and FAT1, that form a molecular zipper, creating filtration slits approximately 40 nanometers wide.
The Starling forces govern the rate of filtration across this barrier. The glomerular filtration rate, GFR, is determined by the net filtration pressure, glomerular capillary pressure minus Bowman's capsule pressure minus oncotic pressure, multiplied by the filtration coefficient, Kf. Normal GFR is approximately 125 milliliters per minute, 180 liters per day. The kidney then reabsorbs 178.5 liters, excreting only 1.5 liters as urine. The mesangial cells sit between capillary loops in the glomerulus and serve regulatory and phagocytic functions. They contain contractile proteins. They can contract to reduce the filtration surface area and lower GFR in response to angiotensin II. They clear trapped immune complexes and debris from the GBM. Now the clinical consequences of barrier disruption. When the slit diaphragm is damaged, as in minimal change disease, where podocyte foot processes efface and flatten, the negative charge barrier is lost. Albumin leaks massively into the filtrate. The result is nephrotic syndrome, massive proteinuria greater than 3.5 grams per day, hypoalbuminemia below 3.5 grams per deciliter, edema, classically periorbital and dependent, and hyperlipidemia with lipiduria. Minimal change disease is the most common cause in children and responds dramatically to steroids. When the GBM itself is attacked, as in Goodpasture syndrome, where anti-GBM antibodies target the alpha-3 chain of type 4 collagen,
or when immune complexes deposit in the GBM, as in lupus nephritis or IgA nephropathy. The result is nephritic syndrome, hematuria with dysmorphic red blood cells and red cell casts, proteinuria, hypertension, and acute kidney injury. Diabetic nephropathy, the leading cause of end-stage kidney disease in the developed world, causes progressive GBM thickening and mesangial expansion, followed by nodular glomerulosclerosis, the Kimmelstiel-Wilson nodules, and eventual loss of filtration function. Microalbuminuria is the earliest detectable marker. Alport syndrome results from mutations in genes encoding type IV collagen chains, causing structural GBM defects, presenting with hematuria, progressive renal failure, sensory neural hearing loss, and ocular abnormalities. The glomerular filtration barrier is not a passive sieve. It is a dynamic, electrically charged, molecularly precise structure. When it fails, the consequences ripple through the entire body. Understanding its anatomy is the foundation of understanding nephrology. Thank you for watching Medical Sciences Unfolded.